Many other times we hear of someone drinking doom, someone ingesting a very dangerous chemical, someone collapsing to the ground because they were alone in a room and they've ingested a dangerous chemical like doom, or they were famine and they've suddenly collapsed. Okay, what do we do in this uh, situation? Okay, this is where we're going to discuss all the principles and how we can help such people with organophosphate poisoning, because this is an emergency situation. So organophosphate poisoning is not something new, because this is a type of poisoning which has been happening in our society for quite some time. Okay, organophosphate poisoning is a toxic condition caused by exposure to organophosphate compounds, mostly which are pesticides. Okay, so the brief mechanism of how this happens is organophosphate poisoning irreversibly inhibits acetylcholinesterase. Okay, acetylcholinesterase is the most important enzyme in this situation because it cleaves acetylcholine, okay, through a process of hydrolysis. Okay, so when this poison inhibits this acetylcholinesterase, it leads to the accumulation of acetylcholine at the synaptic junction, which has different receptors such as the muscarinic receptor, the nicotinic receptor, and the CNS receptors. Organophosphate poisoning, as earlier said, can happen at any time, anywhere. Okay, it can be in a household occupation, it can be in a military setting, okay, or military action environment where people are fighting or outing for different reasons. It can be latrogenic, it can be through intentional or unintentional contamination of food sources. Just a reminder to say organophosphate poisoning causes about 3 million deaths worldwide each year. Okay, so with that highest burden, which mostly occurs in these developing countries in low and middle income agriculture regions. Okay, for us in Zambia here, agriculture is a very important sector in our community, in our country, and that's why we have a high number of organophosphate cases due to our setting, because we're a low and middle income country, and most cases are due to intentional or self poisoning, and mortality can exceed even up to 20 to 30% where medical care is limited. Okay, so with that being said, the main component for us to understand organophosphate poisoning is to look at the pathophysiology, how this poisoning happens and how it causes all these presentations that we are about to talk about. Okay, so the enzyme acetylcholinesterase is responsible for the breakdown of the neurotransmitter acetylcholine at the nerve synapses. Okay, so an example of organophosphate poisoning, which we can also refer to them in this lesson, we can call them anticholinesterase, because they are going to work against the acetylcholinesterase, so we can call them anticholinesterase. This can include certain drugs, nerve gases, insecticides. Okay, so these are examples of anticholinesterase or organophosphates. Okay, they can be certain drugs, certain nerve gases, and insecticides. So the main problem is that these insecticides or drugs can cause a buildup of acetylcholine at the synapses. Okay, so why is it that the buildup of acetylcholine is dangerous? Okay, or it causes the body to react in a certain way? Okay, The buildup of acetylcholine leads to a disruption of nerve and muscle function. Okay, in the vertebrae, hence it causes death by paralyzing the respiratory muscles. Okay, so in short, if this poisoning is not taken care of promptly, it can cause or lead to death. That's why it's an emergency in our setting. Okay, with that being said, we're going to explain step by step and go deeper into the pathophysiology. Okay, so acetylcholine is one of the main transmitters of the vertebral nervous system. Okay, it is released at a certain cholinergic nerve ending and may be excitatory or inhibitory. Okay, so the main function of acetylcholine is that it initiates the muscular contraction at the neuromuscular junctions. Okay, so the acetylcholine receptors fall into two main classes. We have got the muscarinic and the nicotinic receptors. Okay, so now once acetylcholine has been released, it it has to only have a transitory effect because it is rapidly broken down by the enzyme acetylcholinesterase. Okay, so not to confuse you here, what I'm trying to basically say is that acetylcholine is a very important neurotransmitter which is responsible for initiating muscular contraction. Okay, now as you understand in your physiology, there is what we call a nerve has got what we call a presynaptic junction and a postsynaptic junction. So when acetylcholine is released, it has to be broken down by this enzyme called acetylcholinesterase. Now, in this type of situation, this is where the organophosphate comes in because it's going to attack the the acetylcholinesterase, the enzyme responsible for breaking down the the acetylcholine, so leading to the accumulation of acetylcholine, which has many presentations which we're going to look at. Okay, so as I was explaining, the nerve has got what we call a presynaptic neuron and a postsynaptic neuron. Okay, in between there we call it a synaptic cleft. Okay, so in the purple region there, let's say, or let's imagine to say the purple region there is what we call the acetylcholine, which is mostly in the form of a vesicle. Okay, so when this acetylcholine, which is in the vesicle, is released, it goes and passes through the synaptic cleft and binds onto the postsynaptic region there, which has got different receptors, which can be muscarinic and nicotinic receptors. Okay, so now this acetylcholine cannot bind if it is not cleaved by the enzyme acetylcholinesterase. So imagine if that doesn't happen, there's going to be accumulation of acetylcholine, which is going to further lead to what we call a cholinergic crisis. Okay, so we're going to explain more of that in detail. Okay, so acetylcholine or acetylcholinesterase is an enzyme that hydrolyzes, okay, the neurotransmitter acetylcholine to choline and acetate. Okay, cholinesterase is secreted by nerves at the synapses and the muscle cells at the neuromuscular junctions. Okay, so organophosphate insecticides act as what we call anticholinesterase by inhibiting the action of acetylcholinesterase. So the key point to not get confused when understanding the pathophysiology is just to understand that the main character in this situation is acetylcholinesterase, the enzyme which cleaves uh, acetylcholine into choline and acetate. Okay, so when that enzyme is affected, it leads to a buildup of acetylcholine, which causes different cholinergic crises, which I'm going to look at. Okay, with that being understood, the primary action of organophosphate poisoning is is inhibition of the acetylcholinesterase. Okay, so acetylcholinesterase is the enzyme that degrades the acetylcholine into choline and acetate, and the acetate is found at the central and the peripheral nerve system, okay, at the neuromuscular junctions, okay, and the red blood cells. So organophosphates inhibit acetylcholinesterase by phosphorylation, okay, through a process of phosphorylation. So once acetylcholinesterase has been inactivated, the acetylcholine accumulates throughout the nervous system, okay, resulting in the overstimulation of muscarinic and nicotinic receptors, okay. So the clinical effects are manifested via activation of the autonomic and the central nervous system at the nicotinic receptors on the skeletal muscle. So I would like us to imagine the acetylcholinesterase to be something which is very bad for the body if if it's left to accumulate for a specific period of time, because it leads to overstimulation of the muscarinic and nicotinic receptors. Okay, examples of muscarinic receptors, we've got the M1, okay, which are found in the CNS. We've got the M2, which are found in the CVS. We've got M3, M4, and M5. Okay, in nicotinic receptors, we've got the NN and what we call the NM. So all these receptors is where acetylcholine has to bind after it has been cleaved, or after it has undergone hydrolysis, okay, by the enzyme acetylcholinesterase. Okay, organophosphate poisonings can be absorbed cutaneously, they can be ingested, they can be inhaled, or they can be also injected. Okay, although most patients rapidly become symptomatic, the onset and the severity of symptoms depend on the specific compound, the amount, the route, the exposure, and the rate of metabolic degradations. Okay, so in our setting, most of the time these patients orally take these poisonings. Okay, so the most common route that we have here for this poisoning is oral ingestion. So now coming to the symptoms and manifestations of organophosphate poisoning, they can be divided into three categories. Okay, we've got muscarinic effects, nicotinic effects, and CNS effects. Remember, the muscarinic effects because of the muscarinic receptors, the nicotinic effects because of the nicotinic receptors, and also it can also seed into the CNS effect there. Okay, so we have got a good mnemonic to remember the muscarinic effects. Now, for you to remember these muscarinic effects, okay, that are caused by the buildup or overstimulation of the muscarinic receptors, you need to remember that this happens. There's going to be fluid leakage in all the orifices of the body. Okay, so from your anal region, you're going to have diarrhea. From your reproductive system, you're going to have you're going to be removing urine. Okay, from your mouth, you're going to be salivating. Okay, you're going to be sweating profusely. Okay, that's what we call it diaphoresis. Okay, so in short, just imagine to say you're going to have fluid leaving all the openings of your body. Okay, that's the easiest way to remember muscarinic effects. Okay, so we've got the easy mnemonic to remember this is Dan Bell's. Okay, so we have got diarrhea, is one of the presentations, urination, meiosis, we're going to have bradycardia, okay, going to have bronchospasms, bronchouria, and we're going to have emesis, which is just simply vomiting. We're going to have lacrimations and also what we call salivation. So you're going to be removing fluids at all your orifices or openings on your body. Okay, that's a sign of poisoning. Okay, just to simplify it, we've got a diagram here. We can use a mnemonic Danbells, or you can use another mnemonic called Sledge. Okay, so salivation, lacrimation, urination, diarrhea, GIT upset, and emesis. For Danbells, we've already talked about it. The D can be for diarrhea, diaphoresis, urination, meiosis, bradycardia, bronchospasms, bronchouria, emesis, and excessive lacrimation and also salivation. For nicotinic effects, we have got a mnemonic which we're going to use, which is going to be match. Okay, we're going to have muscle weakness and paralysis. We're going to have adrenomedullary activity increase. We're going to have tachycardia. We're going to have cramps of the skeletal muscles, and we're also going to have hypertension. For the CNS, we've got another mnemonic which we're going to use. We're going to say 2C, 2D, SHM. Okay. So if you are very good at knowing this or memorizing, you can just keep it in your head. 2C, 2D, SHM. So confusion, coma, disorientation, depression, headache, malaise, and seizures. Okay. Those are the CNS effects. Okay, so with that being said, the other symptoms and signs which can present or what kills the patient most of the time is what we call paralysis of the respiratory system. Okay, so there's type 1 paralysis, or which can also be called acute paralysis. Okay, so it develops within 24 or to 48 hours. Features can include the muscle fasciculations, muscle cramps, muscle twitching, muscle weakness. Okay, so the muscle paralysis involves the respiratory muscles, leading to respiratory failure, and that's why we put these patients on ventilatory support immediately they come to our setting, because we know that this poisoning, the main goal of what's going to happen, the patient is going to have end up in respiratory failure and is going to require ventilation. So we need to put all patients who have organophosphate poisoning with supplementary oxygen. The other thing that we do for these patients is type 2 paralysis, or the other presentation is type 2 paralysis, okay, which is an intermediate syndrome. Okay, it develops after the acute cholinergic crisis. So when there's overstimulation of the muscarinic receptors due to acetylcholine buildup, it leads to what we call acute cholinergic crisis. So the presence of marked weakness of the neck flexion with the inability to lift the leg, there will be common cranial nerve involvement. Okay, so those supplying the extraocular, most patients survive with ventilatory support. Okay, so it's very important to put these patients on ventilatory support. So we also have type 3 paralysis, okay, or organophosphate induced delayed polyneuropathy. Okay, it's just a sensory motor distal axiopathy. Okay, so after ingestion of large doses of certain organophosphate NSAIDs or chronic exposure, after 2 to 3 weeks, there can be an acute poisoning episode. Okay, so we need to monitor these patients who have treated for organophosphate poisoning. So the presentation can be distal muscle weakness and sparing of the neck muscles, cranial nerves, and proximal muscles. So recovery may extend up to 1 year, and high dose methylprednisolone is beneficial for such patients. So how do we make a diagnosis of someone who comes in with organophosphate poisoning? Okay, so there are certain investigations we need to do for these patients. Okay, so within the first at least 4 minutes upon the arrival, we need to get a full blood count. Okay, we need to check for also after we do a full blood count, we need to check for the presence of acetylcholinesterase in the red blood cells or in the plasma. Okay, because the plasma cholinesterase is a liver acute phase protein that circulates in the blood plasma. Now we need to ask ourselves the question to say, which one is more sensitive between red blood cell cholinesterase or plasma cholinesterase? The answer there is red blood cell cholinesterase, which is more specific when we find the cholinesterase in the red blood cells. Okay, so the other investigations you can do you can check for electrolyte imbalance. Okay, for these patients you can check for hypermagnesemia, you can check for hyperkalemia. Okay, so you can check for all those things. Okay, you can also check for hypoglycemia just to make sure that this patient is okay. You can also check for the liver function test. Okay, because you know the liver function test and abnormal values indicate that the liver has been trying to excrete or has been trying to excrete those toxic substances. So we need to also do a liver function test. Okay, we need to do a renal function test. We need also need to do, when you do a full blood count, we also need to do a differential count to check for the leukocytosis. Okay, we need to check for the hemo concentration. We need to check for the metabolic and respiratory acidosis. Okay, we also need to check for elevated troponin levels, elevated amylase levels. Okay, we also need to check for elevated liver function test results as we've talked about. Okay, so the other things we can do for these patients, we can do a chest radiography. Okay, which may, or chest x-ray, which may show pulmonary edema. On the ECG, we can do an ECG. We're going to find an elevated or a prolonged QT interval. We're going to check for an elevated ST, okay, segment, and we're also going to find inverted T waves. Okay, so with that being said, the principles of management for these patients is we have to ensure what we call our advanced trauma life support protocol. Okay, we're going to, which in this case will start with the normal parameter starts with airway, breathing, and circulation. But in this case, we are going to start with the decontamination. Then we're going to do the airway, the breathing, and circulation in that order. Okay. So we're going to also do gastric decontamination. This is where, and we're also going to put the patients on fluids, more preferably normal saline, and we're going to give muscarinic inhibitors like atropine and acetyl esterase reactivators such as pyridoxine. Okay, so with that being said, gastric lavage should be done if the patient arrives on presentation less than 1 hour after the incident happened. Okay, most of the time it's the person who's brought the patient to the hospital is able to tell you when the poisoning happened. Okay, if it was less than an hour, gastric lavage can be useful. Okay, we can also give activated charcoal, which has shown in some settings to show it really helps. It shows a good it gives a good outcome. Okay, so the immediate management, you have to assess and record the glycoma scale for this patient. Okay, we're going to look at the pulse rate, the BP. We're going to auscultate to make sure this patient is not in shock. Okay, we're going to put the patient in a left lateral position for them to, and the head should be lower than the feet to prevent them aspirating. Okay, so these maneuvers I'm talking about here are after you've done your decontamination. Now, as a medical personnel in the hospital, when you're doing your decontamination, you need to be very careful. Make sure that you're always wearing gloves, and you at least ideally take a patient for a bath immediately, or you bath the patient, okay, with some water, just to remove the chemicals. Okay, you do your airway, you remove the secretions as the patient comes in, remove any secretions, you assess the GCS scale. Is this patient breathing properly? If you always put them on after removing the secretions, you always put them on ventilatory support. Okay, additional O2 support. Okay, so you give them some oxygen. Okay, you cannulate them, you put them on on you give them IV support and put them on and some normal saline, some fluids. Okay, so as you're doing that, you're giving oxygen because this patient has got a high chance of them going into respiratory failure. Okay, they're going to have respiratory distress if they're not given that oxygen, because this organophosphate poisoning can cause type 1 paralysis, can cause type 2 paralysis, which is very dangerous for this patient and can cause death. Okay, so after you do all these parameters, you make the patient lie in a left lateral position, or if they're not having those massive secretions, you can make them sit up in a propped up position. Okay. Then eventually, after you've stabilized the patient and the BP is okay, you after giving those fluids, you catheterize the patient, you monitor the urine output. Then eventually, you can give them you can start them on atropine. Okay, okay, just to reduce the bronchouria. Now we're going to look at the doses of atropine which you need to give them. So just what I was explaining is that the decontamination is preventing further exposure. Okay, you remove the contaminated clothing, or the belongings should be removed and discarded in a ventilated area. Okay, you irrigate them with water, wash with a soap and water. There can also be ocular decontamination with water only. Just clean the eyes with water. Okay. So gastric lavage or activated charcoal may be considered only if the patient presents within 1 hour of ingestion. Okay. Please put that in note. Only within 1 hour of ingestion. Okay, so gastric lavage does not decrease morbidity or motility. However, it may be performed if the patient presents within 1 hour of ingestion of the organophosphate agent after initiating therapy with atropine or an oxym. Okay, gastric lavage involves substantial risk of aspiration in patients with increased secretions, okay, and decrease in mental status. So you need to be very careful when you're doing your gastric lavage as well. Okay, so following resuscitation, initial resuscitation and treatment, activated charcoal can be given to the patient presenting within 1 hour of ingestion. Okay, the standard dose of activated charcoal is just about 1 gram. Okay, the max dose you have to go at is 50 50 50 grams. Okay, so these are very important principles because they help you treat the patient with what you have. Okay, because you might be in a resource limited center where you find the hospital at that particular time the atropine has run out. What do you do for this patient? You still need to save a life, and you can also try to use activated charcoal by after you do your stabilization, decontamination, you ensure your ATS protocol. You can also do after you've done your DABC, you can also give activated charcoal while you're waiting for uh, the actual drug to come. Okay, so patients with cholinergic toxicity with organophosphate poisoning are treated with atropine or and an oxym therapy. So now the mechanism of action of atropine or oxym. Uh, Atropine is the antidote, and it competes with the acetylcholine at the muscarinic receptor and prevents a cholinergic activation. So atropine, remember we said the acetylcholine keeps on building up because the organophosphate poisoning has blocked the enzyme, the acetylcholinesterase. So now what happens? Atropine comes in now instead of just fighting the actual the poisoning, it just blocks where the poisoning wants to go, or the acetylcholine wants to bind. So it prevents the further accumulation of acetylcholine from inducing or causing overstimulation of the muscarinic receptors. Okay, if used in sufficient doses, atropine is potentially life-saving uh, in several toxic conditions or in organophosphate poisoning. So an oxime such as pyridoxime, since atropine does not bind to the nicotinic receptors, atropine only binds to the muscarinic receptors. It is ineffective in treating neuromuscular dysfunction. So we need to supplement the treating of when you give atropine. Also need to give pyridoxime because it's responsible for uh, acetylcholinesterase reactivation. Okay, so it reactivates the enzyme which the poisoning blocked. Okay, hence it treats the muscular dysfunction. Okay, so the pyridoxine simply activates or reactivates acetylcholinesterase. Okay, so it's effective in treating both muscarinic and nicotinic symptoms. Okay, so now the dosing for organophosphate poisoning atropine should be administered at a dose of 2 milligrams IV. Okay, so this dose should be increased or doubled every after 5 minutes, or depending on the literatures, or but the dose should be doubled every after 5 to 10 minutes. Okay, given repeated doses in escalating doses, or doubling the dose each time. So if you give 2 milligrams, and the next 5 minutes you can give 4 milligrams. Okay, after 10 minutes you can give 6 milligrams, just like that. So why doing that? Because your goal is to achieve what we call atropinization. Okay, you're supposed to experiencing some dry bronchial secretions and decrease the wheezing. Okay, so we're going to keep on doubling the dose. Okay, atropine dosing should be titrated to a therapeutic endpoint of clearing respiratory secretions and cessation of bronchoconstriction. Okay, so with that being said, so patients who do not respond to a high dose atropine therapy may require treatment with epinephrine. Okay, initial epinephrine therapy for patients whose heart rate is below 80, or who are hypotensive with an adequate heart rate of 80, despite receiving a dose of high dose of atropine therapy. So we need to compensate or add on atropine if these patients do not respond to a high dose of atropine, because you keep on doubling the dose, keep on doubling, the patient is not responding. So you need to look at this patient might be in a bradycardic state, and you need to also give something to boost their bradycardia. To take them out of bradycardia, we need to give them an epinephrine, okay, a vasopressor. So as you are giving this atropine, you need to monitor the patient. Okay, the patient should be assessed at least every 15 minutes to check the adequacy of the doses. Okay, so if the clinical features, the parameters you need to check for with the patient on atropine, you need to check for the heart rate. Okay, the pupils. If there's dry mucosa, you need to check the BP every 15 minutes. You make sure the systolic is greater than at least 80. Greater than 80. You need to check for bowel sounds. You need to look at the mental state, because excessive giving of atropine can cause the patient to be agitated, okay, and can cause the patient to go into mental instability. You need to check at the you need to check for the fever. Okay, if it's greater than 7.5, you also need to check the oxygen saturations. Okay, so we need to monitor aspirin at least every 15 minutes and look for all these signs. Okay, so as we've talked about, we just observe those sounds and the bowel sounds, everything we've talked about, just to avoid the patient, to avoid the toxic effects of aspirin, or the patient going into atropinization. Okay, because atropine can be toxic if it can be toxic to the patient if we overdose. Okay, so we need to monitor it very well. Okay, so what are the signs of so what are the features we can, or let's start with, what are the features of atropine toxicity? So as we said, the patient can be in a mental instability state. There can be confusion, there can be pyrexia, there can be urinary retention, they can be agitated, there can be bowel ileus, they can go into hypertensive crisis, or their hypertension can go up, they can go into a tachycardic state. Okay, so you need to be very careful, because atropine can cause all these things. And the other features we need to look out for is atropine can the two features used to assess atropine adequacy. Okay, to target endpoints, we have got clear chest or no auscultation with no wheeze. We've got a heart rate between one greater than 80 beats per minute. Okay, pupils no longer pinpoint. Okay, we have to check for the systolic to at least it has to be 80 greater than 80. Okay, milligrams of mercury. Okay, millimeters of mercury, sorry. And also we have to look at the dry axilla. Okay, so those are some of the things we need to look at. Okay, so after we've given our atropine, we need to supplement. If we're giving, if we have pyridoxine, we need to give pyridoxine. So we need to give pyridoxine, which is responsible for reactivating or making the acetylcholinesterase enzyme reactivated again. Okay, so pyridoxine should not be administered without concurrent atropine in order to prevent worsening of symptoms. Okay, so you need to these two need to go together. Okay, you have to start with the atropine, then you come to the pyridoxine. Okay, so with that being said, the dose for pyridoxine which you need to give is 1 to 2 grams IV as a loading dose, and begin as a continuous infusion of 200 to 500 milligrams per hour. Okay, so it can be titrated to over 15 to 30 units. Okay, and then it can be repeated in 1 hour if necessary, if there's still muscle weakness which has not been relieved after repeating 10 to 12 hourly. So we continue to give pyridoxine as long as there's evidence of acetylcholine excess. Okay, so the pyridoxine or the axons work by reactivating the acetylcholinesterase that has not undergone aging. Okay, and therefore is less effective with the methyl compounds and nerve agents. Okay, so in some cases the patient may start convulsing. Okay, so you need to control, or if the patient becomes agitated due to the toxic effects of the overdose or toxic effects of atropine, we need to control the agitation. Okay, so we need to give at least these patients, we need to give them diazepam to reduce the neuromuscular damage and prevent the respiratory failure. Okay, so seizures are uncommon in oxygenated patients. Seizures are uncommon in oxygenated patients and more common in nerve gas agents. Okay, such as soman. Okay, the control of seizures, the first line in organophosphate poisoning is not phenytoin is not recommended. So we can use diazepam. So lastly, we can also talk about the complications of organophosphate poisoning. The complications include respiratory failure, seizures, there can be aspiration pneumonia, there can be delayed neuropathy, and eventually it can lead to death. So eventually, after treating these patients, they are stable and they are now good to return to their normal life. We need to counsel these patients. Okay, we need to, it's a multidisciplinary approach. We can also do work with our psychiatrist doctors to counsel these patients. Okay, counseling to the poisoned patients may reduce chances of a repeat attempt at the poisoning. So it enables the healthcare personnel to improve the quality of treatment and minimize the cost of therapy and period of hospitalization. So we can also do family counseling. Okay, this helps the family members to cope with the situation and accept the patient as they are. Okay, so with that being said, there's a good chance of the patient not coming back with that same situation, because people can do the same thing over and over again if we do not treat the root cause. Okay, so with that being said, thank you very much. Hope you've understood